Hi, I'm Dr. Art Bartolozzi, and I'd like to talk to you about knee replacement surgery. Knee replacement surgery has revolutionized the way we manage patients with severe knee arthritis. Prior to that time, patients with knee arthritis suffered. There were techniques that did not involve resurfacing of the knee that were much less effective than knee replacement surgery. The advantage of knee replacement surgery is it can restore your knee function to nearly normal. And when I say nearly normal, it depends on what activity level you start with. But most patients who qualify for knee replacement surgery are disabled. So, the symptoms you need for knee replacement surgery are severe pain, severe interference with your daily activities, and also an associated abnormal x-ray. Patients with minor knee dysfunction or minor achy pain or no damage on an x-ray are not good candidates for knee replacement surgery. Patients who are young, patients who are active, patients who play sports are generally not good candidates. Patients who are heavy also make very difficult patients for knee replacement surgery because the excess weight will wear on the artificial parts, and by virtue of being heavy, and I'm talking about in the upper limits of normal or beyond that, with a body mass index over 40, those patients have a significantly increased risk of perioperative complications, blood clots, infection, bleeding, wound healing complications, and death. So we don't take this surgery lightly. I'd like to discuss for you exactly what knee replacement involves. If we take a normal knee with a kneecap, and if we peel the kneecap back, we can see the articular surfaces, which are cartilage basically. So as the knee wears out, the cartilage surfaces wear out. And these little washers are called the meniscus here and here. And these menisci wear out so that the bone touches bone. And when that happens, it's a very painful condition. I've seen patients who've had knee replacement where the bone has been on bone for so long that the bones have actually polished each other, just like a seashell on the beach being polished by the sand. So all three parts of the knee, the front of the knee, the inner side of the knee, and the outer side of the knee can be addressed with knee replacement surgery. It's important to understand that as we do knee replacement surgery, you don't get 100% pain relief because there are structures in the knee that can still be painful. You still have your own ligaments, your own tendons, your own muscles. The bursa around the knee can be painful, so that you get most pain relief. Most people get about 85% pain relief, but there still can be some nuisance pain. Also important to understand is that once the knee is replaced, if you have substantial pain, you should care for the knee by not doing too much activity. You're not permitted to jump, you shouldn't squat, and we discourage running. Now some patients go back to skiing, some patients go back to playing tennis, but generally it's like a car tire. The more you wear it, and the more you use it, and the more you drive it over the cobblestones, the faster the part will wear out. And that's true for knee replacement. Now let me just describe for you exactly what a knee replacement is. Because some patients, as I did as a medical student, think that the knee replacement is replacing the whole knee. And it's really not that. What a knee replacement is taking the actual knee surfaces with all the parts that are worn and removing the parts that are worn and replacing them with metal and plastic. So if we take this model, for example, we would take the femur, which is the thigh bone, and we basically will make these cuts on the femur in a manner that exactly fits the shape of the part that we're going to put on the knee. So this is the femur made of metal, and the femur is snapped, is glued, in most cases cemented into place. And then the tibia is cut perfectly, and a small socket is made in the tibia. So you can see there's a small socket and the flat surface, and cement is applied, and the tibial plastic component is placed on the knee, and that becomes the knee replacement, so that the surfaces that move and glide are made of metal and plastic. And finally, in most cases, the kneecap is resurfaced. So we don't remove the kneecap, we simply shave off the cartilage and glue and cement on a button. I want to mention that concept of glue versus cement. Glue sticks things together, and cement basically works like grout. And in the knee replacement, we talk about that, but we don't really use a glue, we use a cement. The reason why that's important to understand is because the cement interdigitates with the bone and essentially sticks to the bone, not by adhering as a glue would, but it sticks to the bone by getting caught up in the interstices of the bone. If you run on a knee replacement, or you jump on a knee replacement, you can dislodge or jar loose the parts. And that's why it's very important for us as physicians to make sure that you're a good candidate. You need to have enough pain, you need to have dysfunction, you need to have a bad x-ray, and you need to be healthy, because surgery does have risk. And oftentimes with knee replacement surgery, patients are older. It's very important that we check your health status. All patients will undergo a thorough medical examination by an internist, and we'll ask you to see one of the internists in our hospital, who will then be your medical doctor while you're in the hospital. Most patients will be asked to donate their own blood, not all patients, but most, and you'll receive that blood back during the surgery. We actually don't lose very much blood during the surgery because we do surgery with a tourniquet, and the tourniquet is applied at the beginning of the surgery, so the surgical field that we work in is basically dry. But after surgery, when the tourniquet's let down, there is some bleeding. What are the risks of knee replacement surgery? We talked a little bit about that. Surgery does have risk, and the main risks are infection, bleeding, some persistent pain, blood clots, and circulatory problems. Those are the main risks of knee replacement surgery. There are many, many other risks of all surgeries you might imagine. So what do we do about those to minimize them? Here we operate in sterile air. The air is filtered as it enters the operating room, and the pressure in the room is higher than the pressure outside of the room, so that whenever the doors are open, the air goes out, not in. Secondly, we operate in sterile air and spacesuits, so that the spacesuits enclose our entire body and nothing comes between us as the operating team and the patient. All patients are given antibiotics prior to surgery, and we have to perform very careful cleansing of the skin because we're very, very concerned about infection prevention. For blood clotting, to minimize that, all patients are placed on blood thinners after surgery, and the blood thinning can consist of either pills that you take where we have to monitor your blood thinning. In some cases, injections are provided for blood thinning, or even aspirin. But the most common medication that we use for blood thinning is warfarin or Coumadin, that's the brand name. And that requires a testing of the blood to make sure that it's properly thinned but not too thin. And we use that for approximately 6 weeks. It's also very important after surgery to get up and around as quickly as possible. So during your hospital stay, you'll be in a bed with a machine that will gradually move your knee back and forth to help the knee limber up, if you will, and also to help it feel more comfortable. And the machine also helps clear the blood out of the knee. So you'll be in the CPM, or continuous passive motion machine, while you're here. We have you out of bed the next day with a physical therapist, and your hospital stay will largely be determined by how quickly you recover. If you're healthy enough, and if you have 2 knees involved, we can perform bilateral knee surgery at the same sitting. In the past, we did not do that, but the system now allows us to do it, and we use a minimally invasive surgical procedure which allows us to perform surgery either with 1 or 2 knees at the same time. The minimally invasive part of the surgery is not just the skin incision, but it's really primarily not cutting the muscle above the knee. The less we cut the muscle in the thigh to get into the knees, you might imagine we have to actually move the kneecap over to get in. The less we cut the muscle, the more quickly you'll recover. And that's what all the talk is about minimally invasive surgery. So it may be a small incision on the knee, but the part size is frequently gauged with approximately the size of your fist. And if you have a large knee, you're going to have a larger incision. If you have a small knee, you have a smaller incision. And finally, in the post-operative period, you will have physical therapy either at home or you'll be visiting a physical therapist. So in the early phase of the post-operative period, a physical therapist can visit you at home, and then after that, you'll see a physical therapist at the therapy center. A knee replacement is a procedure that will get rid of most of your knee pain. It'll help you improve your walking. It does help you improve your fitness, but you have to qualify by being the right age, with the right amount of disability, and with the right deterioration on your x-ray.